I like to think of precision medicine as tailoring a treatment to a person or their disease, and it's specific to their exact disease and their own biologic makeup. So historically, we've had a few keys in our hand, and we've been looking for the correct lock for each patient. And I think where we are now is a lot of our study of the tumors themselves have actually helped us develop more keys. And now we have hundreds, thousands of keys, and we are now testing patients' tumors to figure out which key is going to go with which lock and turn the tumor off.
Dr. Nate Jones is a GYN oncologist and one of my colleagues at the USA Health Mitchell Cancer Institute. In addition to treating women with cancer, his research interests include personalized medicine, targeted therapies, and racial disparities in gynecologic malignancies. Today, we're going to take a deep dive into the science of precision medicine. We're going to talk about what it is, how it has transformed some aspects of care, and what it means for our cancer patients. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Dr. Jones, Nate, welcome to the show.
Thanks for having me.
We are so excited for our listeners to learn more about precision medicine and to hear a little bit about your research and how it all relates to cancering and, of course, GYN cancer, our specialty. Start by telling us, what is precision medicine?
So precision medicine in terms of cancer is the ability to use a patient's the characteristics of either their tumor or their body specifically to help make a treatment decision that would best suit them.
Okay, can you give us an example or tell us how it's different than traditional cancer treatment, like chemotherapy?
If you were to walk through the door with a diagnosis of ovarian cancer, the treatment recommendation would be very generalized.
So basically, everybody gets the same thing, no matter who you are or what your tumor looks like.
That was the traditional treatment approach. That's right. Now, with the advent of precision medicine, specifically for ovarian cancer, there are certain genetic mutations that a patient may have that would change the recommendations in the upfront setting that we would offer them. So they would not necessarily get the across-the-board generalized treatment. We would oftentimes add an additional treatment or offer some sort of maintenance therapy after they complete that initial treatment.
And so technically, when we talk about like testing tumors to decide what medicine, this isn't that new. We've been doing hormonal treatment for breast cancer for a generation or so.
Yeah, I think tamoxifen was in the 70s.
Yeah.
Yeah, tamoxifen was in the 70s. It took a while to get another approval for a targeted therapy, though. I mean, I think it was mid to late 90s was the next approval for, I think it was Herceptin in the late 90s was the next targeted therapy. But you're correct. The hormone targeting has been around since the 70s.
And this is the lock and the key model that you basically, if you could find the thing that starts the engine of the cancer and then take that key away or block that key from entering the lock, then you've got the winning ticket.
That's exactly right.
Yeah, I find that so fascinating. And for those of you out there, you know that in the 1950s, we used to think that every single cancer cell was a clone of the one next to it, and that the only thing that mattered was actually treating the cancer cells. And what we now know is they're barely first cousins. I mean, they might be, distant second cousins twice removed at this point when you think of the generations of cell division that got from the original site to the metastatic site.
That's right. And even a recurrent cancer that has been treated prior, what we understand is that the vast majority of the cells are killed. There are those holdouts who survive that are resistant to the primary line of chemotherapy. And those, again, by default, have a very different molecular makeup that allowed them to be resistant to the initial treatment and likely would benefit from a different type of medicine.
What's the immediate benefit you see from treating a patient with precision medicine?
It's a good question. I do think to have a treatment recommendation tailored to your exact tumor type in your exact body offers quite a few benefits. I think one of them is that you don't have to undergo the toxicities of a potential treatment regimen that's not going to work for you. And on the flip side of that is if you know the treatment regimen is going to work, you'd be more willing to accept those toxicities if you know it's going to either cure your cancer or put it into remission for a long period of time.
Yeah. And I think we also think about the times when we didn't have this information and we would try one, and if that didn't work, try another. Meanwhile, the cancer is growing and learning how to become resistant to both. And now with the precision medicine, we try the right one the first time.
That's right. And I think historically we've had a few keys in our hand and we've been looking for the correct lock for each patient. And I think where we are now is a lot of our study of the tumors themselves have actually helped us develop more keys. And now we have hundreds, thousands of keys, and we are now testing patients' tumors to figure out which key is going to go with which lock and turn the tumor off.
Fantastic. So who gets it, or more maybe to the point, who doesn't get precision medicine?
Unfortunately, studies have shown that minority patients in low socioeconomic categories, in rural settings with not adequate access to care, do not get tested as often or do not get as robust of testing. In my practice, I offer it to essentially every patient that walks through the door who has an advanced stage malignancy or a GYN malignancy.
And are there patients who get tested and test negative for every known lock and key?
Yes. And to be honest, that is, oftentimes, more often than not, that is the case, where patients do not test positive for the keys per se that we have available. But that's still great information to have because we know those patients are not going to benefit from some of these additional treatments, and they do need the traditional chemotherapy at least to start with.
Well, all of this is so cool, but tell me what it actually means. Like, what does it mean for your patients? How do you offer them precision medicine?
So too, my other passion is, disparities in cancer care. And that is a big focus of my research, looking for a molecular basis of disparity in treating women with gynecologic malignancies. We know through, first of all, minority women are underrepresented in clinical trials, specifically here in the Deep South. A large portion of the patients we treat are minority women, Black women, marginalized women, rural population, a lot of poverty here. We know that those patients are underrepresented in clinical trials, and we know that the traditional chemotherapy, even on those trials where they were treated, those patients, while underrepresented, also typically do worse. And yet we still offer them this chemotherapy from a trial that was oftentimes 97% white women on the trial. Mm-hmm. And I sometimes joke that all we have is white girl chemo to offer some of these patients, and I think we can do, and we need to do, a lot better.
And just as a point, take me aside to say, what is it that we think about being a minority, being rural, or being poor that would make a person's genes different in a way that is not a biologic construct? Because we know race is a social construct. Why do you think their genes might be different?
It's a good question. And I think this is a multifactorial. I do not believe any one factor contributes completely. We know that access to care, in the Deep South is an issue. But, even when controlling for access to care, for controlling for demographics, college education, poverty, there's still a large amount of disparity that's unaccounted for. I do believe some of that is biologic, and some of that, we have good examples, and even the way we, prescribe medicine for, antihypertensives. We do sometimes stratify based on a person's self-designated race. We know some of them are going to respond, better to certain antihypertensives. There's studies looking in ovarian cancer where we've looked at basically a percent of African ancestry and differential response to chemotherapy, so worse outcomes with higher percent African ancestry. So I don't have all the answers as to why, but I do believe there's much more to this. There's metabolomics, different metabolism based on ethnicity. So perhaps the way chemotherapeutics are metabolized, perhaps the toxicities associated with certain, chemotherapy regimens, the ability to, access resources to deal with, the toxicities. So perhaps patients aren't getting either the full dose of treatment or the full length of treatment, and perhaps that, contributes as well. In immune therapies, which is sort of a new, relatively new emerging field, there's some evidence that Black women, specifically in colorectal cancer, or the Black patients perhaps have a differential response to immunotherapy. So while I agree that race is a social construct, I do believe the biology has some sort of contribution to that, and to what end and to what extent, we don't have an answer to that at this point.
Yeah, I think there's some really interesting theories out there, and maybe to say that differently, I think they're kind of post-birth theories. We talk a lot about the fact that we're not studying race so much as racism and the generational effects of increased exposure to environmental toxins and the need for environmental justice, increased exposure to the prolonged stress of racism and what that does to generations of DNA that have to live in an environment of higher cortisol levels or poor diet, poor nutrition, those kinds of things. And I think that seeking equality is exactly what you said, seeking different treatments that will respond in those situations, in those environments, while also seeking to improve living conditions, improve environmental justice, decrease racism, decrease, standing cortisol of an African-American patient, and, all of that by improving equality and decreasing racism in our society. Yeah.
Yeah, and I think you hit on a point that I don't think traditionally has been thought of as an environmental factor, but cortisol. Yeah. The being Black in America and the stress of being marginalized and of living in a racist society is absolutely a contributing factor to not just cancer, but multiple disease conditions, hypertension, higher rates of diabetes, of obesity, worse maternal and infant mortality rates, even when controlled for demographic and income status.
So all things we need to work on. How do you feel like precision medicine levels the playing field, or has the potential to level the playing field?
I do think it has the potential, and I think we're getting there. I think, again, in a lot of ways, precision medicine does not take into account the color of a patient's skin, their ethnicity. I do believe that if there are differences among different ethnic groups, those are going to be found with certain molecular testing or genetic testing of those patients. And it's not necessarily going to be, are you Black or are you white? It's going to be or Asian or Native American or Latina. But do you have certain mutations? Do you carry those in your human genome? Does your tumor have those mutations? And if it does, you get certain treatment. If it doesn't, and there's a sort of an algorithm to follow that is in many ways colorblind. Mm-hmm. And I do believe that is sort of the way of the future, where we don't need to be, looking at any molecular basis of disparity from a ethnic standpoint, that a lot of those will just pan out in the molecular testing that we are already doing.
Yeah, no, I love that. So to go back for a second, describe to us kind of how or when you offer this to a patient in your clinic, in your practice.
So I'm a GYN oncologist, and we've come a long way with precision medicine and GYN oncology, and we have a very long way to go.
Yeah, I think in many ways we're behind lung cancer and colon cancer in this field.
And breast, absolutely.
And breast. Mm-hmm.
The algorithms for a breast cancer diagnosis are beautifully large algorithms with many branching points. Lung cancer has made some pretty rapid advances recently in frontline lung cancer, and colorectal cancer has too. I believe we have, but we borrow a lot of studies from the better funded and better studied disease sites. But to your point, I believe any advanced stage GYN malignancy, I recommend sending for their tumor for molecular profiling. And that doesn't always inform treatment decisions in the front line, but I like to have that information in the event that the patient doesn't respond or recurs and we have to switch gears. I like to have that information available. And
that's either a surgery to remove the tumor, laparoscopic surgery to do a biopsy, or a needle biopsy.
That's right. That's right. And there are cases, too, where we offer genetic testing, where we actually have a patient meet with our genetic counselor to determine if there's a potential that they have an inherited mutation that is contributing to their specific cancer.
Well, I think that's a great place to take a break, and we'll come back and learn more about some stories maybe of patients that have been helped with this technology. The USA Health Mitchell Cancer Institute in Mobile is now offering survivorship classes to help patients transition back into life after cancer treatment. The mission of Survivorship 101 and Survivorship 102 at MCI is to encourage and support cancer patients beyond their surgery, chemotherapy, and radiation treatments. This is the latest iteration of a program in existence since 2017. Each course is 6 weekly sessions on Wednesday from 12 to 2:30 p.m. Topics include nutrition, exercise, spirituality, coping skills, family communication, gardening, and craft projects, all as a means of mental and physical healing. Classes are held at USA Health. The 102 program is an advanced class for cancer survivors who have completed the 101 program. For more information on dates of classes or to register for a program, call 251-445-9691. That's 251-445-9691. Or check usamci.com for more details. Registration forms are located at each check-in desk at all Mitchell Cancer Institute locations. Everybody, welcome back. We're here with Dr. Nate Jones, GYN oncologist and expert in precision medicine. So, Nate, you said something about the branching algorithms of some of the tumors that maybe are more well studied than are more rare, say GYN cancers. Tell me what you meant by that.
So I just mentioned these branching algorithms that when a patient is diagnosed with a disease, and we'll take a breast cancer, for example, they do multiple layers of testing initially. And based on the presence or absence of certain either markers, hormone receptors, or mutations or overexpression of certain genes, they qualify for very specific treatments.
And that means they have a lot of different choices for treatments.
They have a lot of different options and a lot of different FDA approvals. And back to the issue of disparity, a lot of studies have been done to prove that these treatments are beneficial for those patients. And in an ideal world, that those trials are well represented with a diverse patient population.
Absolutely. And speaking of that, can you think of a patient that you took care of that was really helped by this technology?
I can think of many instances of patients relatively recently here. We have a high burden of endometrial cancer in our catchment area, specifically some of the high-risk, high-grade histologic subtypes. And in those patients, standard of care treatment is pretty clear up front, but most of those patients are going to recur. And in those patients, we have the ability to use molecular testing to offer them specifically an immunotherapy. And in those patients, we've seen some pretty remarkable successes. Some patients with metastatic disease with a 3 to 6 month expected survival are alive at 2 and 3 years, doing quite well.
Yeah, I have several in my practice as well. And our listeners know a lot about immunotherapy. We've talked about it a lot. I'd refer you back to Helen Bender's story in particular. She talked about coming to MCI for her spa treatment, her 30-minute infusion in a lounge chair, and then she goes on about her day. It's just a different world than it used to be.
It really is. And every time people ask me about this, about whatever type of chemo, I tell them this is not your grandmother's chemo. We're at a very different place.
Let's talk more about uterine cancer specifically and health disparities. I know this is an area that you really have hit on some very interesting discoveries. Tell our listeners more about where your research is taking you and where you think that future is.
So, interesting question there, because when I started after I graduated fellowship, I really had a hard time deciding what my research interests were going to be or how to apply my interest in precision medicine at this new job here in the Deep South. And it was immediately apparent to me that a very large percentage of my patients were Black women, and they were presenting with advanced stage, high risk endometrial cancers, for which at the time, even treatments were quite limited. We had a couple lines of therapy, and really at that time, after the first line of therapy, it was sort of dealer's choice. And
18 months max.
Yeah, it was awful. So, I sort of developed a passion for trying to apply precision medicine and see if there's any way we could help identify those patients that would potentially benefit or help drive a decision for specific therapy. And sort of in the meantime, immunotherapy became available for endometrial cancer patients, and we've really been able to, I think, sort of change the story for a lot of those patients with recurrent cancers. And a large majority of those are Black women with very awful initial diseases that we've done a really good job with, I think.
Yeah, absolutely. And I think that those discoveries have really translated into improved survival for all women with uterine cancer, including women born with a genetic mutation that would put them at increased risk, like we talk about Lynch syndrome, the syndrome that connects uterine cancer to colon cancer. And I also think of the patient population who present initially with very low stage uterine cancer, but then unexpectedly have a recurrence. And we've seen a huge improvement in that group as well. And I'm hopeful that those discoveries translate to the other hormonal cancers as well, the breast cancer population, the prostate cancer population, and probably, as you've said, those cancers are better studied than our uterine cancer population. But we know that all the hormonal cancers, unfortunately, are still not as well controlled as we would expect, given the improvements we've seen in cancer screening.
Yeah, and you make another really good point about that some of our early cancers, despite our best efforts and despite all the data we have, still recur and can be very bad players, even though it appeared they were, cured with surgery alone. And, I think precision medicine is doing a lot, and we've looked at some molecular subtypes, specifically in endometrial cancer, where perhaps there are some of the early stage cancers where we normally wouldn't recommend treatment, that perhaps we should be offering sort of a full court press with chemotherapy and perhaps with radiation in the upfront setting to fully cure those patients. And then perhaps some of the more advanced stages are actually better players than we would think, and they don't need that full court press, and we can back off a little bit of the full dose radiation and or the full course of chemotherapy.
Right. And treat with those hormone blockers.
That's right.
For longer periods of time. No, I think it's such a fascinating time to be in cancer and cancer biology. And I think the more we know, the more we dive into this, that this is where the cures lie. A long time ago, and I won't say how long because that would date me. My father advised me in medical school not to go into cancer because, and I quote, "Dad, if you're listening, we'll have that solved in 5 years." And unfortunately, we now know that cancer is not one disease, it's hundreds of diseases, and that it is not one cure. But cure looks a lot different in a lot of different ways. And we're now learning that living with metastatic cancer to the extent of your normal life expectancy is its own cure. So they've even changed the definition of cure to say that it's dying of something other than cancer.
That's right.
And so to that end, kind of how do you think this is going to get us there?
So, I think there's some really exciting advances in precision medicine, that are already, a lot of them already out there and in clinical practice. I think, as with a lot of science, the science is ahead of the data in a lot of ways. But, the sort of one of the hot topics right now is liquid biopsy. So we spoke about like having a recurrent, tumor and the need to biopsy that. In certain tumor types, we treat with 6 cycles of chemotherapy based on some pretty old studies. And that's generalized across the entire population that we treat. There's the question of, do some of those patients only need 3 cycles? Do some of those patients need 9 cycles? And this is being studied actively in some of the multiple myeloma is one of those where they look at minimal residual disease. And that's based on a liquid biopsy that is becoming quite popular. And I think it's going to be the future of the way we not necessarily diagnose cancers, but we manage the treatment response during treatment and perhaps are able to treat patients better with less toxicity in the patients that don't need as much treatment, perhaps more toxicity in patients that need more treatment, but we can inform them that if we treat to this point, that likelihood of a cure is much higher because we're actively monitoring the burden of tumor throughout their body using very highly sensitive techniques.
Right. And for those of you who are wondering what liquid biopsy is, I think the most common current application is now doing the Down syndrome test in pregnancy through a blood test that we use the circulating fetal DNA. In this case, the translation is the circulating tumor DNA to say how much is there, what is its genetic makeup, and is it of the harmful, quote unquote, or friendly variety.
Yeah, and the thought is if there's active tumor growing, it is going to be shedding tumor DNA just as a natural part of its growth or just of its surviving. And that would be detectable in your bloodstream circulate. So it would just be a blood test oftentimes that would be done that could tell if you have cancer or not. And perhaps this could be a screening tool for patients. They can get a blood test at their annual visit to see if they have any evidence of an early cancer. I kind of think the sky is the limit here. Again, the science is a little bit ahead of what we know, but I think it's very intriguing science, and I do think it's the next frontier. And one other area that I'm really interested in that's not been very well studied at this point, but using precision medicine to predict toxicity. And if there was a way to determine which patients are going to have adverse reactions, we could start treating those patients with supportive care sooner or even preemptively to prevent some of the side effects and actually get them through their full course of chemotherapy that they need.
Right. Or choose something different to begin with.
That's right.
No, I couldn't agree more. I think it is a fascinating science, and we can't wait to watch your many discoveries in the future. Dr. Jones, I can't thank you enough for coming to the studio on a busy OR day and making time for our listeners to learn more about precision medicine.
It's been a pleasure, and I appreciate the opportunity.
That was such a great episode. I love how Dr. Jones talked about precision medicine as the key and cancer is the lock. We're always looking for ways to turn cancer off. I also appreciate the recommendation for molecular profiling and genetic testing for women with advanced cancers. And of course, this applies really to almost any cancer these days, to gather as much information as possible. And this ultimately leads to patients having more options. I think it's super exciting, and there's so much promise in this field of medicine. I also love how passionate Dr. Jones is about improving cancer treatment and outcomes for Black women in particular. This is so important in the Deep South for health equity and all the factors that play a role. And he's right. We've got to do better. Thanks again for taking the time to listen to this episode. We so appreciate you and hope you'll join us next time. And remember, cancering affects us all. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're going to be doing 2 special episodes throughout the season. We're here for all of those questions, and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.